You gotta be somebody.
You gotta be somebody.
Who's that?
I'll trade you. Candy, give me a seat right here for you.
You can see.
Give me a seat right here. Oh, no, this is okay.
That is not true. That one is one.
No, we can squeeze you in. Oh, plenty of room.
No, that's okay.
Yeah, me too. Hi, Robin. Hi.
Well, somebody said you got a job, and I said, I kind of want to.
Miss, what's your name?
Yeah. Thank you. Usually
Kids at home, no pets. I have lots of neighbors.
It's a little scary, right? I had it.
I don't think so.
Yeah, well, you know, my hair freaks out, as soon as I get in the sun, it just turns white. And so, except with my roots before I get dark, and so my mom, who's my hairdresser, she says, let's get a little darker. She says every time, Mom, it does no good to do that in the summertime, because as soon as I go out for 10 minutes, it'll be that way again. So I said, just keep it flat, and I'll look like a Q-tip, but that's okay. Okay.
I can get one of these. I did not.
Yes, and I think we'll have to,
You're always
make
in
some
that
decisions
too,
and
too.
whatever, yeah.
You can do some backgrounding.
Yeah.
Oh, no, yeah, no. We've only met in like.
Oh, good. You know, I do have, oh, did you, is that one time that you did all the, like, that was so pretty. Yeah, but the one in the hallway. Are you gonna send that one? Okay. I'll have to go look, I didn't pay attention to it. I usually look on the way out, but. I was too.
It's about 15 seconds early. I figure it'll be time by the time you get started. And I didn't want to be late because someone might object. And if they will miss some important part. First off, does everybody have an agenda that needed an agenda? Is there anything that is not on the agenda that you believe someone believes should be? Yeah,
Yes, absolutely, we got it.
thank you.
I'll take them too. Christy? Thank you.
Fall asleep and look at that agenda.
Yes, thank you.
The,
Campbell?
Oh, okay.
okay. If you are a guest and would like to speak to the group, please get your name on the list. So, again, if you may have scores. And we have the usual cast of characters showing up because they think they should be. Well, should I introduce all of our guests? We have so many. Who is that?
Oh, I think we've got somebody very
Lily, would you check the list and see if we have the names?
Did you want to speak? Anybody want to speak?
No? Okay then, that's okay, yeah.
It's okay. The big event tonight is Shannon with a single in. And her quarterly report.
Yes. The big event, huh? Wow. Okay, so here's the reports. You know, what I may do, we usually bring 10, there's usually plenty, so if there's, what I can do is, Christina, you and I can share.
Yes,
We can
absolutely.
pass some of these for people to share there. back
Maybe
to
we
back.
can share it all.
Thank you.
So, did you want to go through the agenda in the order that it's presented, or did you want to have Shannon go first?
I'm thinking it was gonna work too good.
I'll be the flipper, the official flipper.
Yeah, you can, I'm just a listener, see what's going on.
Got it.
Yeah, we should do that. It is an item on the agenda that was skipped over, introduction of guests. Any comments or questions from our guests? I don't know your name, sir.
I think he wants your name.
Hmm?
I think Dick wants your name.
Conrad?
I know you. I know you, okay. And how many, you have comments? Yes. Yes.
Me? No, I have no comment, sorry, I was just waiting. It's gonna take me a while to get used to being in this position.
Campbell? No. Okay. Then we can move it, Jim. That's what they all think, the admission process.
Okay, my apologies, normally Shannon goes last on the agenda, but
Oh.
that's okay, no worries, go ahead.
Wherever you want me to go. Well. maybe I should-
And there we set the tone for
Okay, so for those of you that come, that have been here, this is my quarterly report. It's the same every quarter, but some of you guys are new to this. So every quarter, I come and I usually present kind of the results of some of our quality metrics for the clinic for the prior quarter. So this is for quarter one of this year, which is January, February, March. So this first slide on page 1, you've got the triple aim, that's what it's called. And for folks that aren't familiar with that haven't been here before, our quality improvement program at Unity Care Northwest is really based on the Institute for Health Improvements, triple aim. And that really just means that they have 3 kind of priorities: improving the quality of care, improving patients' experience of care, and reducing the cost of care. So really in all of the measures that we choose for our organization, they usually fall to one of those 3 areas. Okay. So we can go to the next page here. You can see the first slide. This is providing healthcare services to more people, so unduplicated patients. You can see that in quarter 1 we were at 489. So it was the first quarter actually that we didn't dip further. We were right almost the same as last quarter. So that's good. And as I go, if there's questions, interrupt me. In terms of the first quality measure, this is adult hypertension patients. So this is folks that are diagnosed with hypertension in our clinic, that have their blood pressure control. Our 2018 goal is 80%. In terms of our color scheme, you'll notice that it says there's a little key there, but yellow means that we're making progress towards our goal, green means it's been met, and red means we have not met it, and actually it typically means we've not gone backwards. And so you can see on this particular measure we have actually gone backwards. At the bottom of the graph, you'll see the different quarters I'm comparing it to, and you'll also see what our denominator is for how many people are there. So for example, in quarter 1 of 2018, there were 67 patients in the clinic with a diagnosis of hypertension, and 72% of them had their blood pressure under control. So what I would say about that is that certainly not going the right direction this first quarter, but what I would also say is if you look at us compared to like benchmarks nationally, we're actually right in the middle high area. So 72% is actually pretty decent anyway, but organizationally this is a measure we've been struggling with. And so it's not just Point Roberts is what I guess I would say. And there's a few things that originally I thought contributed to it, and that was that about a year and a half ago, maybe 2 years ago, a lot of our providers adopted new guidelines that were put out for blood pressure control that were actually a lot looser. So our guideline, our measure, had a higher bar than what the new guidelines did. And so when providers adopted them, then we started to see that decline, right? Because which makes sense. But we don't change our measure in mid-year because remember that we also compare ourselves against statewide community health centers and nationally, and so whatever we're measured against, we have to keep reporting on until the next year. So the interesting thing is the next year, people caught up and they changed the measure, right? And so we thought, great, we're gonna do great. And then they changed the measure again and the guideline again. And this time they made it a lot stricter, which should have actually meant that we went up, because if our guideline was lower and our measure was lower and the guideline went up, we should have seen it going up. It didn't. So we have now kind of our data folks digging in and trying to do audits of records to see what's going on and where we're at. Again, it's not that we're doing bad, but we want to identify why we're going in the wrong direction instead of moving up. So hopefully I'll have more information for you next quarter to know what we found out. Okay, page 3. This is diabetic retinal eye exam. So if you've been diagnosed with diabetes, one of the things that is recommended is that you have an annual retinal eye exam. This is a measure we've always struggled with here because many folks on the Point have a trouble getting to Bellingham or wherever they can go to get retinal eye exams. The last couple years, we've brought up our retinal eye camera that we have in Bellingham and brought one of our nurses up here to be able to do those. That's been really helpful, so you've seen that, we've started to make some progress there. One of the challenges really is that equipment you can bring up, but it's not easy. It's a big piece of equipment and it's challenging. So, and then we've also had challenges where we try to book up as many as we can get done that day, and then we have a whole bunch of people show up, which is sad. So Renee typically tries to overbook that so that we hopefully get as many in as we can get. So anyway, that's good, but the other thing I will say is that since it's an annual measure, if you bring up your camera once a year, you're gonna have people that are, you're gonna have your people do again every year. So getting higher is tough, because the same people you did last year you have to do again, and if you wanna impact the measure, you gotta keep doing more. So this will be something that we kind of have to keep looking at. We hope to be able to bring the camera up more, but it's hard because again, it's hard to transport, and we have to pull one of our trained RNs from Bellingham's floor, who is staffed there, to come up and do it. That's who's been trained to do it. And of course, there's a high demand for the camera in Bellingham too. There's a huge amount of diabetics in Bellingham. So it's always trying to figure out when we can do that. But
Could you go to the way, get a bus and just take the people from here over there?
Well,
we can't transport it anyways. Not allowed with ours. So.
It would be cost effective, I don't think.
Is it a major process for someone to learn to be the person who does it?
No, not that. It's more the equipment. So it's more the equipment. So like Fran, did you ever get trained?
I didn't.
I didn't think so. So, we've debated that. We could train Fran to do it as an RN. The challenge isn't so much that, it's the equipment. Somebody still has to bring the equipment.
Right.
And setting it up, and it's quite large,
Oh, that's
cumbersome. It's not easy, and like this last one, we were trying to coordinate it again, and Renee, we just didn't have enough people. We just did to validate the cost of it, so
This is one of those things that, there's things like, if you're diabetic, a lot of people who are diabetic will buy into the medication management, taking that, getting their blood levels checked, they know that. Trying to get them to do their foot checks annually and their retinal eye exams is not something that many diabetics prioritize. They think they're pretty good if they do it every other year, every few years. So it's a lot of education effort on these guys' part to try to get them in. So we're continuing to look at if there's ways for us to do that. A couple years ago, we checked into buying another camera, not for Point Roberts, but for Ferndale, because our Ferndale clinic is, getting bigger. It's quite expensive. We got lucky with this first camera because Community Health Plan of Washington who's a health plan that all the community health centers are members of, and the CEOs for all the community health centers are actually the board of this plan. And so they made an investment with leftover like dollars from their quality one year and bought cameras for people who were interested, potentially one per site. So we got that one free to us. But to buy one, I forget what the cost was, but I was actually quite surprised at how expensive they are. So, and that wouldn't be worth the cost for one up here with the numbers we have. So, I think the good news is that, you know, we're going up, and just for people in this room, if you guys recall, not too long before this Q2 2017, we were actually at 17%. So we are, you know, at least improving. Okay, the next slide is diabetes patients with poor control of their hemoglobin A1C, which really is their blood sugar, right? So on this one, lower is better. This is the number of people who are out of control. So I have to really give Natalie, she hasn't seen this yet, but this is one of the, 17% is one of the lowest providers in our whole organization. That's really amazing. So, you know, her goal was 29%, our organizational goal was trying to get to 20. I think we have maybe 3 providers that are under 20 out of maybe 15 or 16 or 17, something like that. So kudos Natalie, because this is not easy, especially I would say it's even more difficult at a Point Roberts clinic, because remember that where all of our Ferndale and Bellingham sites are primary care clinics. Here we're, you know, primary care and urgent care. So, you know, we have a number of diabetics who come in to see us for only urgent care and actually get their diabetic care elsewhere, but we're measured against the whole population of somebody diagnosed. So that means that if you've got an out of control diabetic who comes to us for, let's say, a sore throat and gets their care elsewhere, but they're still out of control with their diabetes because they're not managing it well, it counts against us. So that's still, for her to be at 17 is really saying something, because she has a large urgent care population. So, and you can see the improvement over time. So great work on that. Okay, next one is page 4. This is patients 18 and older with a BMI, which stands for body mass index, charted, and a follow-up plan documented if the patient is overweight, obese, or underweight. So part of the thing that we're held accountable to for adults is that if the BMI, body mass index, is out of range, normal range, under or over, then you have to not only have taken the body mass index, but you have to have a plan documented in the chart for how you're going to address that with the patient, or how you address it with the patient. So you can see that we've kind of been anywhere from 62, 57, 55, 56. She's kind of going back up again. Her goal for this year is 62. That's actually pretty good when we look at records, you know, comparatively, especially with the population again that we're serving here, because not everybody who comes in is seeking primary care for us, and most people who are coming in for acute care don't care about the body mass index, right? I mean, you have a sore throat.
It's not a priority.
So pretty good there, and that's a large N, right? You have 398. So she's doing, you know, doing fine there. The next one we've actually slid back a little bit on, that's female patients aged 24 to 64 with a pap smear and or HPV testing. So HPV is, if you get an HPV shot, it can actually help prevent cervical cancer. And so obviously you are trying to have negative HPVs in your patients so that they don't have the risk for cervical cancer. So our goal is 60%. We're not far off that. We were real close. Last year our goal was lower. They made that. We kind of dipped a little bit. The total numerator was, our group is 115, so it's a decent amount of people, but not a huge amount of people. It doesn't take very many people out of 115 to make that swing a few percentiles, so I'm not even convinced this is statistically significant, the difference between those, but still, something we're paying attention to. We haven't been able to get further. And you know, we've talked about this before, the laws of diminishing returns and where that point is in Point Roberts, and I don't know where that's at, right? It's gonna be real hard to know that. In primary care, where you just do primary care, like Ferndale and Bellingham, we have really good comparisons to know how we do compared to other primary care offices. And we can kind of say, you know what, if they can do it, we can do it, kind of thing, right? Unless your population is really different, which ours really isn't. Up here, when you're not doing 100% primary care and it's kind of a 50-50 deal, trying to figure out how high we can get in our percentages is something that's kind of a little bit of a guesstimate. We try to kind of keep raising the bar every year, and you know, at some point we're going to see that we're just not being able to get above that place. And so I will be interested to see, and then over the next results, because we've been hovering in this kind of 50, mid-50s to high 50s for a while. So it makes me wonder if we're getting close to that point. So we'll see. Childhood vaccinations. This is one measure, by the way, that is all of our organization. We do not measure this by provider. So this counts all of our patients in the whole organization. So just to clarify. Now you see there's only the N is only 74, which is very small. And that's really because the measure on this is a very specific measure. It's, you know, patients receiving their childhood vaccination rates by age 3, and so you can see how many they have to be here. And so the eligibility for the age and the different, you know, the different pieces, and it makes that number very small. It's not like we only have 74 kids, but only 74 that met all the criteria to be counted in this particular measure. And the good news here is that we're going up. 53% though is still not good. You know, you want to be in the 90s, you know, we really want to be in the 90s, right? One of the challenges that we've had with this one is that people are probably aware, but in Whatcom County, there's quite a resistance to childhood vaccinations, right? So Whatcom County struggles a lot to get higher vaccination rates than in other counties because there's just kind of that resistance to it. And I would also say that they changed the requirement. I don't know, Fran, do you remember Christy, 2-3 years ago, where they actually added 7 new vaccinations to the requirement? Well, if you have a hard time getting the parents to get them the rose vaccine, and you add 7 more, well, good luck.
And they eliminated any catch-ups, right?
Yeah.
If your kid is behind, they don't get counted. They're just, and it counts against us.
Yeah. So what's interesting what Natalie's referring to on that is that the CDC has a catch-up schedule. So if your kid's behind, you can catch up, you can do these different vaccinations to kind of what they call catch up. Well, the CDC recognizes that, the health department recognizes that, but most of the plans do not. So we measure what the hardest restriction, because that's what we have to get measured against. We measure against the hardest requirement. And so here we're at 53. What's interesting about this is, and I haven't told these guys this either, but we just got a big certificate and award in the mail from the state and the health department for having, you know, one of the best vaccine rates in the state, and all the work we've done to improve them. And that cracks me up because we're at 50%, right? And that's because they count the catch-up schedule. And so a lot of our kids enter care late, right? We serve a large low-income population, a lot of people that move around, and so, you know, we get kids into care. At one point, our average was 10 months old. Well, if you're starting at 10 months old, you're already way behind, right? Way. So we've been able to work that down, and so we're trying to do more marketing and different things to people to get, you know, parents, more outreach to parents. And we've gotten that average down to 6 months, which is better, but it's still behind. So if you start off behind, you never, you know, they don't count you if you catch up. So, anyway, we're still working on it as much as we can, but there's some reasons behind it, and there's some efforts that we continue to try to make. So, patients with colorectal cancer screening. So our goal this year was 43%. Natalie and her team have already got to 46. I know this is something that Christy, you were working on. She said I was the colorectal cancer's queen. She's been trying to push this. Who? Oh, is it you? Who wants this test? No one. No one. So kudos, Fran. So good work on that. Okay, we'll flip the page here. So now we are moving into out of quality and into patient satisfaction, so the experience of care measures. Green means that we met our goals for first quarter. I do want to go mention a couple of things here. If you look at the top piece is kind of on experience scores. So same day response to phone questions, saw provider within 15 minutes of appointment, provider involved you in your healthcare decisions, discuss what makes it hard for you to get your health care taken care of. Those are things like transportation, you know, access to medications, housing, different things like that. Asked about your mental or emotional health, test results received in a timely manner, and a specialist appointment as quickly as needed. And so you can see how we ranked this quarter, and we do pretty well. But I will also remember, we see a small population, right? So, you know, if you look down at the one below it, you will see this is our quality one satisfaction scores, and you look at how many people are there. And that's why one of the things that we try to do is a rolling 12 months, because any one quarter, means really nothing, right? I mean, 6 patients out of, we see about, last month we saw 100. So if you're getting 6 people who are responding to the survey out of 100, that's a small number. So what you try to do is, instead of taking that, because statistically that's not significant for 1 quarter, we try to then say, okay, how are we doing over the whole last year? So we can, and it's still not a huge number, but it does give you a little bit better data than having just 6, right, in a quarter. So note that, the down below it tells you how many responded per quarter, and then kind of what our mean average was. And Dick, I am sorry, my assistant actually printed these out this time for me. I try to put these on their own slides so you don't have to try and get your reading glasses out and see the number. And I've been doing that, and I didn't catch that from her. I'm sorry. So I'm really sorry. So what I will say is, just for your benefit, under the mean scores, overall satisfaction, the 4-quarter average is 93.3 out of 100, just so you know. Appointment weight is 93.2 out of 100. Phone attendant courtesy and helpfulness is 94.6. Reception staff courtesy and helpfulness is 94.6. Provider wait time is 90.4. Provider assistant courtesy and helpfulness, that's the Christy and Fran, 98.1. Provider listening, 97.1. Provider time spent, 96.2. And provider explanation of care, 97.1. So good results, but again, small number.
Do other clinics have better participation in the survey? This is, even when you take it over the course of the year, you're just getting the same small number against an even larger. It's
You
not
are,
like
having said that though, and of course, I'm not a statistician, so don't quote me here, okay? We hire a vendor to do this for us. All the community health centers pretty much in the state use the same vendor, so we're able to really have a pretty equal comparison benchmark, right? Both in the results, but also how questions are asked and they have a percentage of patients they're required to get a hold of per provider. So this actually meets that. But I think what's interesting, and probably why it's a little bit funky here, is it's 1 provider. So in Bellingham, if you're hitting that percentage for every single provider, you can see theirs, but you can see it against all providers too, and you look at the whole clinic. And so they can say, you got, 200 surveys this quarter for the whole clinic. So you can look at that data and say, okay, for the clinic you've got a really good number to look at. When you only got 1 provider, it doesn't add up, right? So from a statistical standpoint, this is the percentage that they do for each of our providers. It just is not, I personally don't think it's as valuable when it's only 1 provider and the numbers that we have. Having said that, what I will say is I think we can go back, and even though it's a higher number, you can still see, if I went back from the start when we started this, we have performed at this level the whole time. This has been a high satisfaction clinic from the people that are getting care here. I can't speak to the ones that don't come in, but they're, that, but I can speak for the ones that can say for the ones that do. I've never seen us ever, I don't think, below 90 on any one of these that I can remember. So that's pretty good over a history of several years. So,
5 years.
Yeah, I'm not sure we've used the same vendor for 5 years though.
Oh, no.
So I'm trying to be, because before that we were doing our own surveys, sending them out, and that's good, but I just, it's different than having an external vendor do it, Okay, next page, page 7. So I also try to always provide what has been provided in terms of narrative on those surveys back to us. And so they have a section, they have a question that says, what did you like in your last visit to your clinic? And so this is the positive feedback that we've gotten. And then there's a question also that says, what would be an opportunity for improvement or something you'd like to see improved? And this time we didn't have any comments about the improvement piece. Typically when we have any, there aren't very many, and they're almost all the same kind of area. They're usually, love to see the clinic open more days, longer hours. A couple times it's been, oh gee, I had to wait for half an hour, or something because I was worked in today, and, so those kind of things, but most of them are around office hours and wanting to extend office hours, so. Okay, and then the last page moves into, page 8, moves into the 3rd pillar, which is kind of being a good steward of resources. And reducing costs. So one of those pieces is obviously you want to minimize the number of uninsured patients that you're seeing, right? Helping people get enrolled in insurance. And so again, most people here that have been here and heard me say this before, but for folks that are new, we were at 13% in 2013. You can probably figure out why that changed. The Affordable Care Act went live, and the Affordable Care Act went live. Washington State decided to go ahead and accept the Medicaid expansion. A lot of states didn't, we did. And so when you do that, a lot of our patients are Medicaid eligible, and so that really reduced it. Some folks, your area here in Point Roberts, there's probably more on the exchange than in our Bellingham and Ferndale clinics. So because you serve more commercial folks, and the income levels are higher than where they are in our Bellingham and Ferndale clinics, the folks we serve. So there's more that have gone in exchange, but there's also those that have gotten Medicaid expansion. So that is really the result of why that uninsured rate has dropped over time. So now what I wonder is, you see that 2017 and 2018 have gone up a little bit. I mean, it's 1%, it's not huge. But one of the things I wonder about, and this is just reading tea leaves, right? So this is not scientific, don't quote me on this. But recently, in the last, 8 months or something, they've repealed the individual mandate, right? Requiring people to be insured. And so in Bellingham and Ferndale, that didn't change much for us because vast majority of people that got insured were on the Medicaid expansion. Up here, there was more people on the exchange, not a ton, but more. And so if it's no longer required, then I don't know that maybe some of those folks didn't just drop off insurance. They didn't have to pay for it. It's just a thought in my mind of why I think that could be, but it may or may not be right. I've been wrong before, yeah.
Next, what's ED visits?
Okay, so that's the next one we're gonna go to. Cost of care. So the last slide here is our Community Health Plan of Washington, which is the plan I mentioned to you, Medicaid. And that just, the ones behind it, Apple Health expansion, those are just names of the different plans that fall under Medicaid. So two areas that we look at as being good stewards is our generic prescription rate. So when possible, you want to prescribe generic prescriptions as opposed to brands so that you can save the patient money, but you can also save the insurance and all of us, especially with Medicaid, right? You want to be good stewards of the resources. So our goal is 87%. You can see we're right in that ballpark. What I will say though, organizationally, is that we have higher numbers of prescriptions written per patient and higher numbers of expensive prescriptions written per patient as an organization. We have been kind of trying to drill down on that. So even though we're pretty close here, prescriptions are really expensive, so it doesn't take very much to make a big difference financially. We originally thought that was due to the fact that we have a really robust HIV program in our Bellingham clinic, and we serve a lot of HIV patients, and those meds are really only brand name meds and really expensive. So we've been under the assumption that was the reason why for a long time. We can't get the data, we can only get the data from our own pharmacy. So in the health plan, these people are filling prescriptions everywhere. And so it took us a number of years to be able to get that data from the health plan. They were able to provide it. So we've been assuming all along, that's the reason. It wasn't. We did into it, and that wasn't the reason, ironically. Those were actually fine. We did fairly well in those areas. So then we kind of thought, well, maybe it's hepatitis C, because we have a large hepatitis C program, and those are expensive. But the state, when they did their hepatitis C program, actually backed out the cost of those meds in that, so it's not part of that structure. So that's not it. So now we're back to the drawing board, digging some more to see what's next. We have some ideas. We actually think it might be specialty providers. Because remember that we're in managed care, we're the primary care provider. When we refer a patient out to a specialist, and they see the specialist prescribes the medication, we're still at risk for that patient. We're their gatekeeper. There's pools of money to pay for those services. So if the specialist prescribes medications and they prescribe brand names or really expensive medications, it still comes out of those pools. So there's a possibility that's it. So that's what we're going to drill out next. So, it's a matter of research. You got to do a lot of research on a lot of charts and figure out what's going on.
Cardiology, pulmonology, and rheumatology.
Yeah.
Those would be the three specialties where, the Xarelto drugs, things like that, that are still very expensive.
Yeah.
And no generics available on Flutter or stuff.
And
rheumatology.
Yeah,
But having
rheumatology
said
and
that,
pulmonology.
when you say that there's no generics available, that is, we're much higher than the other community health centers. So that should be the same issue for them then, right? So what's different about our specialists in Whatcom County? And so And I don't know if there is. We're just trying to, you know, when you look at these things, you start thinking, okay, what is feeding into those costs? And you start kind of saying, okay, this could be one area, let's drill down on it. That's what we did, didn't work. There's another one, didn't work. Now we're starting a new one. So we're gonna keep drilling down on it, but that is one of our areas. Having said that, on the flip side, we're like one of the best community health centers with ER utilization. That's what ED is, ED visits. So you're trying to prevent avoidable visits to the emergency room. Having people come into your clinic as opposed to going into the ER for routine kinds of things. And so this report is how many ER visits there are per 1,000 members. And you know, you see we're at 499, our goal is under 450. I didn't put it on here, it isn't on here, but the community health plan of Washington average for all the community health centers is up in the high fives. So we're doing quite a bit better than the average of the community health centers, and we have for a number of years. When I first started with the organization, we were actually on the high end, and the clinic has worked really hard. All new clinics have worked really hard to do good follow-up care with those going to the ER, trying to be proactive, getting people in timely, taking triage calls, that kind of stuff, and that's really made a difference. So that one we're doing quite well in. So that's my report. Are there questions? Comments?
Thank you, as always. Awesome presentation.
Question.
Yeah.
How much would it cost to break out statistics for urgent care versus primary?
How would what? What's the question?
What would be the cost of breaking out the data for urgent care versus primary?
We don't have the ability in the EMR at this point, which has been a bit of a bane of our existence, because that's part of the issue in setting the standards for the quality measures, is that we can't differentiate them in the chart. So any patient that comes in, I get assigned as the primary, it goes into the EMR that way. We don't even have a way of differentiating that they're primary somewhere else.
But wait, let me just clarify that though. We could have a way to do that, but that wouldn't matter, because organizationally, we are held accountable to the same standard regardless if they're seen for urgent care or primary care. That's why this clinic is so unique compared to our Bellingham and Ferndale clinics. We are a primary care organization, not an urgent care. As a primary care organization, the health plans hold us accountable as a primary care organization. So every person that comes through our doors, we're judged on the same set of measures. It doesn't matter if they're only seeking us urgent care or not. So that's why we've set our goals lower for Point Roberts than we do our other clinics, because it's not possible for them to achieve the same standards in that case. But it's still always a challenge for these guys. And that's why earlier when I said, when do we know when we get to the laws of diminishing return, it's harder for me to figure out what our goals here can get to, because we're not an urgent care organization, we're a primary care. There's nothing for me to compare it against to know how far we can get in that setting. Does that make sense?
Yeah.
Okay.
Looking at this other one, this is the fun of asking the question.
Sure.
Because I've used this kind of stuff. Could this be because your system is doing maybe a better job of identifying and referring people that truly do need to be referred, therefore you've got more people out of specialty care, therefore the cost is higher?
Oh, for the prescription, you mean?
Yeah.
It's possible.
Yeah.
It's possible.
I mean, in other words, it might be kind of an unavoidable good thing because the standard of care is excellent.
Well, you know, it's interesting you say that, because one of the things our CEO we've talked about a bit, is that in a lot of measures, for resources and stuff, we do quite well. This is the only one that we don't. And there are some arguments you can make why this being higher potentially can create other things being lower. As an example, let me just use ED utilization, ER. If our providers are more comfortable handling some things in the clinic and they're prescribing for the patient there, the cost for prescribing will be higher because they're seeing us, but they're not going to the ER, so that's going to drop lower, right? Where some primary care providers like to say, oh, go to the ER, go to the ER, go to the ER. And those higher cost prescriptions might be written by them as opposed to being written by us. Does that make sense? Mm-hmm. So we don't know that. I mean, I don't want to sound like, oh, that's the reason why we're doing really good. I'm just telling you that's a possibility. It's hard to know. I mean, this stuff's, data is great, but data is only as good as what you put in, as what you get out, and there's some things that you can't put in or get out. And so it's, you try to drill down as best you can, and you kind of get some, over years of experience and things you see, you try to kind of get some ideas about where you should look. And like I swear, I would have sworn it was the HIV meds. I would have sworn that was it. I mean, I would have get some serious money. I would have lost. So, didn't turn out to be that. That's why you do need to kind of drill down, right? So.
But also Barb, to that effect, yes, my population is significantly older, significantly more
That's
complex,
true.
and we do manage more internal medicine type patients,
Mhm.
and we do try to do as much as we can in the clinic to avoid sending them to the ER.
Absolutely.
Or, I do a lot of work on the backside for a lot of the specialists because, setting them back and forth to 3 appointments before anything can get done is
Right.
not cost effective, and it's hard on the patient. So if I can do labs or imaging or start things beforehand and get stuff worked out, and then follow up with what they need, which is a lot of what we do, is we're like, oh, they thought maybe this might be a good idea, and we'll go in this direction, and so that does.
Very good point and very true. I would guess that here the population is typically more in the older age range, and there is a lot more medications being prescribed, and you are managing a lot more things here. Having said that, though, I'd be surprised, given the fact that the clinic is only a 0.6 being open a week, and one out of the, you guys do last year, 1,000 visits a year. Last year we did 80,000 visits. So I don't know that yours would influence that number that much. It'd be interesting to find out. That might be an area for us to poke at. We are serving as an organization, our Medicare population is growing too. So it could be that the same reality, yours is much higher, but it could be that the phenomenon of us increasing our Medicare population organizationally is doing it. I would be interested to kind of poke at that because especially at the Point Roberts, to see, I would be, in my mind, I just can't imagine that number of encounters compared to our whole would make that much difference organizationally in that number. But it could be, I don't know. But the growing Medicare of the whole organization could, so.
Well, the baby boom generation
Yeah.
retiring, that
Yeah.
is.
Well, and many,
We're
just,
there.
people probably know this, but a lot of primary care offices won't accept Medicare.
Yeah.
So, we are growing both because of the baby boomer population, but we're also growing because we're one of very few anymore that accept to do Medicare patients.
And people are living longer, so this
Yeah.
increases the Medicare
So,
percent.
this is the thing, you can sit here and think of a lot of really good reasons why this is the case. Are they real? I guess they are, but there's been a couple times where I thought I knew. So.
Take us back to the survey again. Is there anything that we've done, these seven results out of 100 patients, it's such a low
Yeah.
number, and the results then become really sort of meaningless, but is there any way to get at least about 50 of those people to respond? Instead of just-
Statistically getting people involved in surveys, just in
Are
general.
these email surveys that I guess from Don?
Phone
that
surveys.
come out- that come out?
Phone
Oh, phone surveys?
They call folks and they do a phone survey. And what I will say is probably even, so they're able to get the percentage they're supposed to get from this group, but getting more than that, remember too, this is 489 people in the whole clinic. So think how many times those people are probably getting that call, right? When you've got a population of 21,000 patients like we do across the organization, the odds of them getting a call, they're gonna get more than one, but they're not gonna get bombarded. These people are probably getting bombarded because it's a much smaller group. It won't be the 489, because not all of them are coming in all the time, but out of the 100 that do come in, there's probably a good percentage that come in every month because of their conditions. And so they may get tired of doing a survey. You know what I mean? Hard to know. And you can increase the percentage of we could contract to increase, no guarantees that we get more, right? But we could contract with the company to do more. It's quite expensive. So, that would be something I think the hospital district would have to think about if that's something you want to invest in. And I can find out how much that would cost, but I probably have it somewhere because we were actually looking at doing that some time ago for something else and decided in our dental program. We decided not to do it because it was, but anyway, I think it was, if I remember right, for the dental program, it was it was for behavioral health. I think we were looking to increase that some because we have a similar problem with the low end, And it seemed like it was gonna cost something like two to 4,000 a quarter. So it's not huge, but it adds up, so we didn't do it.
But yeah, when you work in statistics and you're doing research, it's really hard to get people to respond. I mean, even professionals, like it's like pulling teeth. You send out 300 and hope 50 come back. You're lucky.
So just so you know how it works is that we give them, there's a way that we upload information, like the schedule to them, and they, so they can know who came in. And that's how they will approach the calls to the patients. And so they're calling them based on those schedules. So how many they have to go through to get the 6? I don't know. But I do think, because it's a small group, you'll probably get these, I don't know about you guys, but I would get tired if I'd already provided feedback and I was happy, for example. I wouldn't want to say I was happy every month, right? When he asks the same questions. Now, if I was unhappy, I might. And it didn't change. I don't know.
When you see the result, is the clinic allowed to encourage people when they go home and get this call to
Renee
Is
does
we grab
rarely,
Renee?
she rarely encourages them.
Well, we've done in-house surveys too.
Yeah,
and
we've
sent them
done
off
papers in
to-
the rooms, they used to send them out in the mail. Yeah, so there's been a variety of different approaches, it's just that people just don't have to do them.
be nice to have numbers that actually could be more meaningful.
Yeah,
Mm-hmm. Well, I will tell you, the thing that I find meaningful isn't so much the percentage that comes out of the raw, the mean number, is the comments that I always find. And so when we get those, that's been really helpful for me in particular, because you do see trends, and we've had conversations here based on those, like, gosh, should we think about opening the clinic more hours? But if we're having a hard time filling our schedules with 3 days a week and our numbers are going down, that's gonna be hard to sustain by opening more hours, right? So we've had lots of discussions about the feedback we've gotten and a few areas that have been consistent. So I find those to be helpful. I mean, it's great to get the positives, don't get me wrong, I mean, the staff, I want them to get those, but I like the criticisms, the opportunities, because that helps me to figure out what we can do different.
and it's been years, like, so if you take that number, over the years that we've been doing it, you got a little bit more workable statistically.
The one other one that we get, that we've heard, probably, there's, the office hours tends to be the one we hear the most of. The other one is like opening more days, the other is opening more like evenings or weekends, right? So one is the actual being open every day, and the other is set different kinds of hours. So those are the most common. Then I would say, you're gonna get, the ones that say, I had to wait 25 minutes, that doesn't happen very often, but it's gonna happen once in a while. And so that's gonna be another common one that you get, but it doesn't, again, happen very often. And the other one that I've heard some is, which we've talked about lots of times, the clinic is, I called the clinic and they couldn't get me in for 2 days, or 3 days, or till next week. And we're saying, because we have typically lots of same day access. So we've talked about, okay, what is our understanding of our urgent care clinic, our access, what should it be like? To make sure that these guys are all aligned with our expectation, and they seem to be on board with that. And what's interesting is you'll hear that once in a while, but then I'll also get a lot of feedback on the positive ones that say, gosh, I called today and they just got me in within a half an hour, it was awesome. So it's hard about getting us kind of, when you're in healthcare, you're gonna get, not everything's gonna be rosy, which I like to see that picture and how it's painted over a period of time and how much information you get, so. Other questions, comments?
That was really informative.
Very good.
Back to the increasing hours and changing hours, well, we're not gonna increase hours, but, is there any discussion about, changing hours to accommodate some of the people that would like to have after hours?
There's been like, I think one of the conversations was here, right? We've had some conversation. The challenge really is that we're only as available as our staff is available. And so, as I've talked with Natalia and her team, they have, with their lives and kids and everything else, very little flexibility to go much later or on Saturdays. Natalia will come in on Saturdays sometimes for emergencies, like they happen, she cuts their foot in the shell, or
Yeah.
she'll come running in to do that. Some people don't have to go to the emergency room, which is great, we really appreciate that she does that. But she has not really been interested in regularly having office hours that time, and it really is not gonna be productive for us to try to find another provider who's gonna work just those extra hours.
Additionally, we have to do the labs in the morning. The labs are an enormous challenge.
'Cause they're fascinating.
Now, to get them down in Seattle.
No, that's not right. We did-
Oh, it's not?
No, it's
just
just the mail,
Oh, okay.
which we now are running into an issue.
Yeah.
So we have to be open early for the labs. So then you have to have part of the staff there early in order to do the labs. And we've done that on Monday because Natalia she starts later and works later, but I still start at 8 in order to get the labs done. So I think more people want to attend to have their labs done than want to have evening appointments. I honestly
We
think
go on one
if you
day,
ask.
we were over there till 6 on Mondays.
Okay.
And it would be difficult as well, with Malia, you know, to have one staff member come in. Malia needs, you know, or no one's in the clinic by themselves.
Yeah.
And for
Right.
continuity and
Yeah,
safety,
right. Yes.
like Malia would
Safety,
need
yeah.
myself or, Frank to come in, and then so
And
we.
nobody knows how to work the front desk except
Right.
for none of us know how to work a computer.
I think nobody wants to know how to work the front desk.
No, that's insurance, that is all, that is out of my scope
I
of practice.
sat there and answered that phone when Renee's not, and believe me, I don't wanna know how to do any more than that.
I mean, we wouldn't know how to take a payment, we wouldn't know how to bill insurance, we wouldn't know how to check availability.
What's funny
That takes a whole degree in
What's funny is
itself.
that people that, you probably remember this, maybe even Elaine, actually you probably do too. You know, back in the old days, when Val was there, you know, and back, you know, that time we were able to send coverage up. So really, we had to cross-train our MA to do that,
Yeah.
and it was always a nightmare. I mean, you know, we got, you know, information wrong, insurance information wrong, because, you know, they just don't do it very often, and it's not their expertise. So it really was nice when we were able to start providing coverage for Renee when she goes on vacation, so that these guys, both for their sanity and ours.
You never know what someone's job is until the day you have to do it.
That's right.
And then you go, oh,
That's right.
I guess they are sitting there with nothing to do, are they?
Well, we never had that illusion.
No, I know you didn't.
We were very thankful.
But
to
I've been
have
in
Renee.
jobs where people were like, she doesn't have to do anything, does she? And then one day they had to come in and help me, and it's like, oh, never mind.
It's Newton's law.
Yep.
Everybody's job is more complicated than you think it is.
That's exactly right.
All right. Thank you, Shannon.
That was great.
That's wonderful. And now I see why we put that in the wrong place in our agenda. Because we need to approve the minutes of the previous meeting.
Oh, okay.
After the meeting today. So could I have a motion to approve or disapprove or something with the minutes from one of our commissioners?
I can't have a voice in that since I was
No.
only appointed last time, so.
Just a move to approve the minutes as presented.
Second passed without objection. All right. Now we get to other business. You've been so patient, Jack. Why don't you tell us what's on the piece of paper?
Our current month payables total $15,220.07, and there's one item to note, the Libbytown invoice for June is $145.03, which includes the installation charge for the district's phone line being moved from Elaine DeBar's home.
Oh, I see.
The current month payroll totals $3,664.80, which represents 36.8 hours for Barb in May, 42 hours for Barb in June, 25.2 hours for Renee, 8 hours for Elaine, and one event for 3 commissioners, and 20 hours for Heather Dixon.
Do you have a printout of those numbers?
I didn't bring one for you, but I can give you mine.
Oh, usually
I bring them,
you bring them, that's why.
and I
Not
provide them all
this.
those papers.
Lots of stuff today.
Yeah.
Well, it's seen on paper, right?
Right, without these.
move to approve the warrants as presented. Payroll,
Well, that I
payroll,
can
sorry.
second since I'm actually here.
Is there objection? If not, that motion passes without objection. Superintendent, now I don't know, are you speaking now?
I'm speaking as the incoming, and then she's gonna have a
So
few
we're
things to
gonna
say,
split the
we're
time?
splitting it tonight. But I have very little to say, so. let's
Divide
see.
and conquer.
Yeah. Just, I want to put a status of orientation on here because I wanted to give a heartfelt thank you to Elaine and to Renee and to Jackie for all of the huge support. Telephone calls answered quickly, emails answered. It's been I have really felt supported, and I just wanted you to know that. And it's an ongoing process, and we're still working, but it's really been a pleasure, as much work as it is. It was a pleasure to work with these people doing it. I wanted to let you know, last meeting you voted money for the new laptop, and we are in the process. We've picked a laptop. I'm gonna be calling Dell to get some specific data. We have been made starkly aware that we really do need backup. And so I'm investigating how we can do that at the best cost. I'm being told that cloud backup has gotten to be reliable enough, that's probably the way to go. And so we're going to follow up on how we do that, because we want to keep the cost on the equipment. We want to get a good equipment that will serve us for a number of years, but not waste any money on stuff that we don't need. So we're looking at it real carefully before we order. By next month, we'll probably have it. One of the things we are going to do is we're going to change to Windows 365, because when you purchase that, you get 5 licenses, and that means that Renee will then also have that program, and if we need to add anything onto Jackie's computer, we'll have these 5 licenses, and so we can put computers on it that are part of our system. So that will be helpful. And that's all I have.
Thank you, that's good. All right, have anything left over, Elaine?
I do. So we chatted, at our previous meetings about the number of hours, and the split, that we've moved. So I was doing 8 hours a week, and Renee was doing 8 hours a week. And we agreed that, with the increased expectation that Barb would, increase communication, so, being able to be more available to have conversations and liaise with the different organizations that we do liaise with. We would take 2 hours a week from Renee and give it back to the superintendent, which is the way it was once upon a time ago. It was 10 hours for the superintendent per week. So that will take effect for June, and you saw it in the payroll costs that her weekly hours are going to go up to 8. Also, as we agreed, I'd be paid for 2 hours a week for the rest of June, and then I'll just be on call as needed after that. The challenge with this job is that a lot of the things that you run into, you don't run into them very often. So you can't possibly teach somebody if it's not there to teach them. So happy to help out as I can in that regard. One of the cautions I do want to sort of highlight with each of the commissioners, though, is that if we continue to get public records requests at the frequency and volume that we are now getting them, you may have to increase those hours. Business as usual is 10 hours a week, and that might include the odd small public records request. But you guys are going to have to work closely with Barb to make sure that doesn't continue, because it's a lot. And, I'm familiar with the files, the file names, where to find them in email, all that kind of stuff. But this is all new to Barb. I mean, she's not seen them. So for her to dig through stuff, it's taking her a lot longer. And so, part of our training time has been definitely eaten up just doing hospital district, public records requests, because we have to sit side by side and do it together. So yeah, just something for you to be aware of, and to keep communicating with, and see how
The other thing that I wanted to bring up is around the survey, just talking about, your survey that you do, and we did ours back in, starting in November. It was also on the list, for this public records request. So we all knew that that request was going to come, that these two people were going to put their hat in the ring to get a copy of that data, and, that has come true. So, I just want to thank Shannon for your partnership early on in the game and getting ahead of that and sort of, paving the way with the clinic staff and that kind of thing. There's a tremendous amount of valuable data in there. There's some wonderful compliments, there's some really great suggestions and opportunities, and unfortunately, there's some pretty harsh negative feedback. And what will happen is that it will end up on the small point bulletin, and that will do us damage, and we have to be prepared for that. And I don't know what you guys are gonna do to get out ahead of that. It's very unfortunate. It's damaging people, it's damaging reputations, and I'm very worried about how it will be posted there, along with any assumptions that are made relating to that feedback. I think that when we put the survey out there, the expectation from the public was that it would be private. Certainly, if I was participating in a community survey, my expectation would be that survey data was private and confidential. So personally, I actually feel very sorry to the public that we've done that to their comments. I think if we're going to do a community survey again, I think we need to take that into account. The balance, either we disclose right out of the gate before you answer this survey, you need to know that it can be made public in any forum that someone so chooses to make it public. And then we see what kind of response we
Did we
get.
get legal advice on whether we do actually have to disclose that information?
Yes.
May I ask a question?
Yes, please.
So in this survey, is there comments about us, obviously there are comments about us as the staff,
Yeah.
that could potentially be hurtful to us,
Yes.
and we will not respond. Okay, all right,
And
thank you.
I'm sorry for that.
That's okay,
Yeah.
thank you.
We talked about this a while ago, but it's been a
Yeah.
while, right? I mean, it's been
It
months
has
since
been
the
a while.
survey. What I kind of shared, just so you guys know with the staff, is that, when we do surveys, and when we have our vendor, Crossroads, does surveys, there's some pretty nasty things occasionally that come through on a provider too, right? Now, we read that, we don't even share that typically with our provider. If it's, what we share is trends, right?
Mhm.
So if I'm getting surveys and repeatedly for this particular doctor, I'm getting feedback that they don't have good bedside manner, or, that they're, not addressing them by their misses, or, some kind of a feedback that's routine, then we share that with them. But I don't share a one-off here and there. I look at it myself, and we'll evaluate it, but we don't share that with them, for that same reason,
For that
right?
reason,
Because
yeah.
you're never going to make everybody happy, and so, but that's what I've told the staff, is this is going to be hurtful if that happens, and I'm sorry for that, because also, when we were talking about doing the survey, and it was suggested here, I was in support of it, because I thought it would be great opportunity for us to see if there was things that we could do as an organization differently to provide service better to the community. And that's what I really hope the goal was. But to do this, that tells me it wasn't the intent. And unfortunately, what's disappointing to me is it was actually suggested by a community member, not a board member. And I thought that was a really good sign on this particular board's perspective and ours to be totally willing to do that, right?
Yeah.
Because we wanted to learn. And I feel a little bit duped, like it was
Yeah.
done intentionally to actually point fingers.
Yeah.
And that is not healthy. I don't think that's actually the point at all of getting community feedback. I was hoping for things that would be useful for us to say, you know what, it would be really helpful if you guys provided this service, and we could look at how we potentially could do that. Or, even if it was things about specific staff, that's okay too. But those are things that we want to look at internally and figure out how to address,
Yeah.
not something you post out there, right? I mean, if I'm an employee of any organization, that's not reasonable or fair.
No.
So I will say, from our perspective, I don't think that we would be supportive of something like that again too. And, you know, as you spoke, you know, when you were resigning, and I spoke too, I will say that that will be a contributing factor to something you think about, to be honest.
Yeah,
Because the staff's already been punished enough, I'm not gonna continue to,
yeah,
so people should know that.
yeah.
Okay.
For sure. So, yeah, so all that to say, we've still got some items on that public records request that, you know, Barb will work on her own, and some items that I will help her with, and do my best with the 2 hours a week I have. And Barb is doing great. She's doing really, really well. I think she's gonna be excellent in the role. I think she'll be a great liaison with all the different groups as well, so, thank you. That's all I have.
We have other topics for discussion.
Not other topics, but something that I was talking to Steve with Kate in my head. The idea of increasing the patient surveys. When I talked about the high cost, one thing that just crossed my mind is when we're looking at for dental, remember that dental has a lot of providers. So that cost is probably pretty high because you're doing it for lots of dentists. So, you know, one provider is a little bit different. So, you know, just keep that in mind. If it's something you want me to check into, I certainly could do that if the district is interested enough to potentially, you know, cover that difference and wanna do it. It may not be very much for one. Just keep that in mind, something you guys think.
But it would be interesting, before we consider doing that, if there was any way to get some feedback on what the level of resistance to being called is, because I think there's a great deal to what you're saying, that because the number of people, when you look at the visits in any clinic situation, you have those people who are there every month or twice a month or whatever, and other people come once a year for their routines. And so those poor people who already have health issues and have to be seen a lot are gonna get called more often out of such a small circle of people.
Right.
And so maybe that in fact would give us more data, but not better data, particularly if they're already going, I'm sorry, I talked to you last month and the month before, please don't talk to me today.
Or that our results go bad because they say, quit calling me, I
Exactly.
don't like you guys anymore.
Yes,
Because
exactly.
you're calling me and bugging me all the time.
Exactly, so.
Well, and I also get called and contacted for labs that are overdue, for imaging that's overdue, for when their appointments are.
Yes.
And that already drives people crazy.
That's
Yeah.
enough, yeah. So it's such a, it is not an easy thing to get good information unless you're dealing with a pool of people that's like 10 or 15 or 20,000. Then it washes out enough that nobody's, if somebody is angry, it's not enough to affect the overall thing. But I think we have to tread with very, very good care on this, because we wanna be here as a service, not bugging them because we want data.
Well, I will say that in our behavioral health program, you know, I forgetting off the top of my head how many patients we have, but it's in the low thousands. And we get lots of complaints from them about getting repeat, like, they call me every month for the survey. And, you know, so if that happens, and that's, you know, in the low thousands, and this is 489 total, and only 100 coming in a month. So, but I just wanted to know, it's a possibility, you know, to address your concern. I think it's something you guys can think about, talk about. As long as we have to make a decision, we can make a decision right now. It can be something you bring up, and I just wanted to know what's available for you guys to say.
Thank you. This. Thank you, Shannon.
Pleasure. So is Elaine, this is your last official meeting?
It is. Yes, it is.
We are
Yeah.
very, very sad.
Thank you.
Well, I'm particularly sad because these guys will probably still get to see you occasionally. I will not, probably.
Well, I don't know, if you're doing like a Christmas dinner.
That's true. That is true.
I think it
Yeah.
should be an honorable mention.
Or you're not gonna meet Robin and come back to every meeting anyway?
We'll see you there next month.
Okay.
Well, and I did promise Barb that I would do that for the first couple of meetings anyway, just in case there were questions that you can't answer
That I
yet,
can't
and
answer.
at least I'm there and I can do that.
So by the time I come back next quarter, you probably, but I just wanna say again, you know, I said when you resigned, but really, you've been such a pleasure to work with. I've really enjoyed it all, the professional working relationship with you. I think it's really improved our working relationship with the hospital district. I think you've been a really good advocate for the hospital district and really helped to share what the needs were of the hospital district with us so we could deliver better. And so I appreciate that. It's been a good partner.
And I have to say from the clinic and for myself, you're the only reason that I'm still here. I would have walked away, quite a long time ago, from a lot of, negative issues and you were a great leader and, yes, this is valuable.
Thank you.
And the staff all feel the same. I think we really, really appreciate the work that you put in and who you are as a person.
Thank you. I don't know that the community has any idea how lucky they are to have all of you guys. Really, you're just outstanding healthcare providers. Yeah.
All right. Everybody's.
Now we're all happy.
You see why I wanted you to go last?
Yeah.
Throughout this meeting, I keep thinking of the words of Mark Twain about lies. Three kinds of lies. He said. There are just lies, and there are damn lies, and there's statistics.
Very good.
All right. If there is nothing else for the good of the order, we adjourn.
If anybody does not want to keep these,